to this. Welcome to this Catalyst seminar in May. We have two talks this afternoon. The first one, Jen Dykxhoorn, which will be for about 20 minutes, and then the following one is Jeanne and Reena, who will be talking for about 30 minutes. So in general, we'll probably ask for people to save questions for the end. We'll have plenty of time for questions at the end. I think that's all the housekeeping from me. My name is David Osborn, in case it hasn't come up on the screen. I'm a professor of psychiatric epidemiology in the Division of Psychiatry at UCL. But I'm delighted not to take up more time, but to introduce our first talk, which is Jen Dykxhoorn, who is a senior research fellow here in UCL's Division of Psychiatry. She's a psychiatric epidemiologist and has a particular interest in social and spatial determinants of mental health and mental disorders. So Jen, you're going to talk to us about inequalities in adolescent and young people's mental health. So over to you.
Great, thank you so much for the introduction. Just let me grab my slides here. Okay. Great. Well, thank you. It's a delight to be able to present as part of the Catalyst seminar today. And today I'm going to be focusing on public mental health with a focus on children and young people. And I will be drawing on the conceptual framework for public mental health that we had developed to provide the broad context, and then specifically focus on some work we've done measuring the incidence of common mental disorders. So, this research is the result of a large program of research that David and I and a number of collaborators were involved in over the last few years. The public mental health program was funded by the NIHR through the School for Public Health Research. And it was a very comprehensive program looking at understanding public mental health and the art and the science of promoting mental health and well-being and preventing mental illness across the life course. So for all of the work that we did, we really tried to take a life course approach to the research, understanding the drivers of mental health in children and young people, in adults, and in older adults. And we had the overall aim of helping support practitioners in public mental health. So at the beginning of our work, we had identified that there was no comprehensive conceptual model to bring together the many factors that shape mental health. So before launching into the quantitative research that I'll present a little bit later, we spent time developing a conceptual framework which summarizes the key drivers of public mental health across the life course. So in order to comprehensively cover the broad knowledge that exists around mental health, we conducted a state-of-the-art academic literature review, a gray literature search of public policy documents and reports, and also conducted consultations with members of the public, policymakers, and practitioners. If you're interested in learning more about this process, we published a paper last year which provides a lot of detail on developing the conceptual framework. In addition to this academic paper, we developed an interactive web tool, and I do encourage you to have a look at this because we think that it's quite cool. It's a way of bringing together this broad range of evidence and summarizing the evidence in a visually appealing way. So you can look at it from a big picture, or you can dig into each individual determinant and get more information. We also try to use the web interface to be able to demonstrate the way that the various determinants are interconnected. So we had identified 55 determinants, and these were organized across 4 levels: individual, family, community, and structural. And while the framework was developed to cut across all age groups and to be a picture across the life course, there are several determinants that are particularly relevant to the mental health of children and young people. So for example, at the individual level, thinking about things like adverse childhood experiences, parenting, attachment, life transitions, identity, these are particularly important and prescient issues for children and young people. So if you were to explore the framework in more detail, you would see, for example, the determinant card here, which has a lot more details about adverse childhood experiences and how those affect mental health, including some helpful resources, some link to lived experience, and also some indication of how these sorts of determinants are interconnected to other factors in the framework. Similarly, bullying also is a key issue for many children and young people. And so this is another example of the determinants card. When we move to the family level, some of the determinants really take on a different meaning when you're looking at children and young people versus adults. So when you think about the importance of family dynamics and family level factors like parenting or attachment or family relationships, these may be very different and they may be shaping the mental health of children and young people in a quite distinct way from what we see for the adults. So again, looking at the family level in a more detail, you can explore attachment or parenting and look at some of the resources there. Just very quickly, moving on to the community level. Again, there are some very distinct and relevant factors that I think are particularly important for considering the mental health of children and young people, including things like community safety, social support, and neighborhood deprivation. So this is, again, an example. The broadest level is the structural level. And here we wanted to make sure that we captured the very broad factors that underlie mental health. Some of the factors at the structural level are really well researched and there's a lot of evidence for. So for example, there's a huge body of literature around inequality and inequity and the long-lasting life course impact that can have on mental health. However, some of the other structural determinants still are emerging in terms of the impact. For example, when we look at things like climate change, there's evidence that these long-term shifts in climate systems have impacts on mental health, but there is still a lot of emerging research to look at that. And the relevance to children and young people is a particular interest as well, thinking about unique factors like eco-anxiety and those sorts of factors. Okay, so that gives you a very brief whistle-stop tour to the conceptual framework. And I wanted to start here because it really is this broad foundation for us to understand how many complex factors come together to shape mental health. So we moved from that comprehensive foundation to explore very specific research questions trying to capture the rates of common mental disorders. So just to very briefly mention, common mental disorders include disorders such as depression, anxiety, and stress. They're highly prevalent disorders that affect a large number of people each year. And they contribute to a significant amount of psychological distress and impairment of social functioning. So the first study that I'm going to discuss today is an incident study that we did across the UK, where we wanted to look at the long-term temporal trends in the annual incidence of mental disorders. So we used de-identified electronic health records, which included over 29 million UK residents. Anyone that's registered to a GP practice was included in this study. And this particular database is called CPRD, or the Clinical Research Practice Data Link. For this analysis, we calculated the annual incidence of common mental disorders per 1,000 person years at risk, and also created stratified estimates based on sex, age, ethnicity, and more. The most surprising finding from this study was, I represented here on the screen, was this really large increase in the rates of common mental disorders in the youngest age groups. So here in the pink, and I think you can probably see my cursor, you can see in 2000, when we started the study, those in the youngest age group, those aged 16 to 24, had 40 per 1,000 person years incident annual cases. However, when we look at 2019, this has over doubled to be 108 per 1,000 person years. So you can see that there is this really dramatic increase over the 20-year period that we're exploring here. You can also see that there is a rise in the second youngest age group as well, so those 25 to 34. So that has increased from 57 per 1,000 person years to 90.7. So this is not quite as dramatic of a rise, but over this period, these increases are really notable. And when we look in detail at some of the other age groups, there are some changes over time, but they tend to be largely stable, and there isn't this huge increase that we're seeing in the youngest age groups. So this result, as I said, this was the most surprising result of our findings, that the youngest age groups were experiencing such an exaggerated increase in rates of common mental disorders recorded in primary care, and especially in contrast to stable or sometimes even declining rates in the other age groups. However, these findings do echo some other research. So there are 2 UK cohort studies that did find increases in depression in adolescents between 2005 and 2015, so the kind of the middle decade in this study. And also the increase in rates of common mental disorders has been documented in other countries like the US. So we thought that this really warranted further explanation. So when we're thinking about it, this increased incidence could actually correspond to an increase in psychological distress and symptoms of common mental disorders. However, there are other possible explanations that we would need to exclude before concluding that adolescents, children and young people, and young adults are actually experiencing high rates of common mental disorders. So, for example, the increases that we observed in the previous slide could be actually due to many other factors. So this could be changes in recording by physicians, so maybe differences in terms of identifying common mental disorders or coding symptoms and diagnoses in the electronic health records. However, since the incidence is stable in some of the older groups, we don't think that this would completely account for the differences that we're seeing. There also may be changing practices in terms of physicians' readiness to prescribe pharmaceutical treatment for mental disorders. Another change over time that might contribute to the increase that we're seeing is actually increases or changes in help-seeking behavior. So potentially the last couple of decades of anti-stigma campaigns and public awareness, maybe those have been making a difference, and this increase in the incidence is actually a good thing, because potentially it could mean that people are more likely to seek help for mental health problems because there may be reduced stigma or more availability and awareness. So what this slide is really saying is that these rates, we don't know what is underlying these rates, and that's why we need to do further research. Which brings me swiftly on to the next study that followed up from here. So we wanted to explore in more detail what's happening in these youngest age groups. And the first question that we had was if this incidence of GP recorded rates of common mental disorders in young people corresponded to increased rates in common mental disorder symptoms at the population level. And we also wanted to see if this increase was observed across various subgroups of young people, or if it was more concentrated for certain subgroups. So we again used the de-identified electronic health records, CPRD, for the diagnosed common mental disorders. And we also used Understanding Society, which is a UK longitudinal household survey that has symptoms of common mental disorders measured. So in the analysis, we did calculate the annual incidence rates, but we also calculated the weighted mean scores on this GHQ, or psychological distress scale. So what you're seeing in this figure, we've truncated the follow-up time in this study so that we could compare to what's available in the cohort study. So we're only looking at the years 2009 to 2019. And you can see overall, we're still seeing an increase in this, in the younger population. And we're still seeing the same distribution that we would expect. The well-documented higher rates of diagnosed common mental disorders in females compared to males. So that's what we had expected to see. On the other side of the screen, though, is our rates of, this is the mean score of common mental disorder symptoms. And so what you're seeing here, this central line is the overall trend. We're seeing an increase in mean score over time. So because these are different rates, in order to compare them more directly, if we were to calculate the change in the decade that we're covering here, the incidence rate would correspond to an incidence rate ratio from 2009 to 2019 of 1.10. And the equivalent relative risk in the change in the mean score here would be a change of 1.19. So this actually indicates that the change that we're seeing in population-based symptoms actually is similar to or possibly larger than the increase that we're seeing in terms of the increase in the symptoms. When we look in some more detail, so again, stratifying by smaller age groups still, we see that most of this is driven by the youngest individuals in our study, so 16 to 19-year-olds. And you can see, again, what we had seen in that previous study, that we're seeing a very large increase over the period of time and somewhat much smaller increases in the other age groups. It's difficult to see these differences in this, which is again from the Understanding Society data, because the confidence intervals are much wider. We're no longer dealing with 30 million people. We're dealing with a couple hundred, like around 20,000 people in the sample size here. So we have much broader confidence intervals. But if we were to look underneath of all of the overlapping lines here, we do still see that the increase in the mean scores from 2000 to 2019 increased the most in the 16 to 29-year-olds as well. So they start with the lowest rates and it ends being one of the groups with one of the higher rates in terms of mean scores. So what does this mean? So this study further provides evidence that there is an increase in rates of common mental disorders in adolescents, particularly in the last decade. We showed that this increase in diagnosed common mental disorders in primary care corresponds to an increase in symptoms of common mental disorders in the general population. We also showed that these increases are not shared across all subgroups. I didn't have the time to show you all of the slides for the different disaggregations, but it seems to be concentrated in the youngest age groups that we were able to look at. We do suggest that further exploration is needed to disentangle what underlying determinants will be driving the observed changes that we're seeing. So bringing this back to what we looked at in the conceptual framework, what are the factors that have changed over this time period that could account for the changes that we've observed in rates of both diagnosed common mental disorders and symptoms of common mental disorders? So thank you very much again for your attention. I look forward to answering any questions that you have, and feel free to get in touch if you do have any follow-up questions.
Jen, thank you so much. That was extremely clear. You covered a huge amount of material there and some fascinating data. Very elegant to see the way that you used the kind of rather rough clinical data that we have available in the UK, but then the very kind of detailed cohort data. Really interesting to see them kind of the dialogue between the two data sources. So thank you so much. There's lots of food for thought there, but we're going to ask people if they can to hold their questions till the end of the session, and we'll then move on to our second talk for the this Catalyst seminar. So I'm delighted, we're delighted to have a rather different topic here, and to welcome Dr. Jeanne Wolstencroft and Reena Anand, who are going to talk to us about speaking about unspoken groups and innovative approaches to addressing inequalities in autism assessment. Excellent, I had the right title, it's come up on the screen, that's superb. So I won't talk a lot, but I'd like to just introduce Jeanne, who's a research fellow at the Great Ormond Street Institute of Child Health at UCL, who's really interested in the impact of co-occurring mental health difficulties in children and young people with neurodevelopmental disorders. And then in a really interesting cross-disciplinary pairing, Reena is a solicitor and former ombudsman who specialises in cases involving vulnerable consumers impacted by the Equality Act and has a particular interest in underrepresentation of specific groups. But I'm sure they will talk about that far more eloquently than me. So I will be quiet and hand over to Reena and Jeanne.
Thank you for the intro, David. I'm assuming the slides are showing up as they should and that you can hear me. It's a pleasure to be here with Reena, to be able to talk about some work that we've been conducting together on a project called Chatter, which you will hear about very shortly. The plan for our talk and how we tackle this topic is that we're going to start by setting the scene and kind of talk a little bit about the links between autism and mental health, and also how this sits within culturally diverse settings and leading you to a paradox that we're going to talk through. And then we're going to talk about the Chatter project, which is what we hope is a potential solution to some of the challenges that are happening out there in the world. Anything to add, Reena?
No, perfect summary.
Sounds good. But before we get into it properly, because of the areas of which we're talking about, it's important that we start with a quick note on the language that we're going to be using today.
So I'll just on the throughout the slides we do use the terms ethnically diverse, Black, Asian, and minority ethnic, and global majority interchangeably, and it's just really to acknowledge that the abbreviation or the term Black, Asian, and minority ethnic we recognise is an imperfect term, and it doesn't really fully capture the racial, cultural, and ethnic diversities, ethnicities, and identities of people that experience structural and systemic inequalities. But it is helpful for us to utilise as a term to highlight the disparities that we'll be referencing in the presentation today.
Similarly, when we're going to be talking about autism and autism conditions, we're going to try and use identity first language throughout. So autistic person rather than person first language, person with autism, because there's a body of literature which tends to suggest that autistic adults prefer identity first language. Again, it's not a perfect use of terminology, and there's lots of debate and variety around how people prefer to use language, but with that in mind, that's the kind of language that we're going to be using today. So the Catalyst seminar series kind of umbrella brings us together to think about child and adolescent mental health. So why are we talking to you about autism today? So autism is a neurodevelopmental condition that affects about 1% of people globally, and it typically can be diagnosed accurately before about 2 years of age, although we know that that's not what happens in practice. And in terms of what autism is, it's characterised by differences in social communication and social interaction, as well as being characterised by a cluster of other symptoms around repetitive and stereotypes patterns of behaviour and sensory sensitivities. Autism is not a mental health condition, it's a neurodevelopmental condition. But I suppose we can talk about it as a psychiatric condition within the framework of the DSM. But the reason that we're really interested in talking about this today is because if you have a diagnosis of autism or meet criteria for autism, the likelihood of you also having other neurodevelopmental or mental health conditions is high. And in kind of a research sense, actually, there was very little interest in co-occurring conditions in people with autism until this kind of landmark study by Emily Simonoff in 2008. And she did a study with children and kind of did a comprehensive assessment of psychiatric conditions in children and found that 70% of the autistic children in her group met criteria for at least one other co-occurring condition, and 40% met criteria for 2 or more, which is really quite a lot. More recently, Lai et al. Have conducted a systematic review and meta-analysis of co-occurring conditions in autism. And in that study, they found that, as you won't be surprised to hear, there's high rates of ADHD in about a third of people with autism. There's also really quite high rates of anxiety. So they were finding rates of anxiety in about 1 in 5. And then some varying other rates and conditions. So things like depression were prevalent in 1 in 10, and behavioural conditions again in 1 in 10. The other important findings from this systematic review and meta-analysis was that the emergence of mental health problems tended to follow a similar trajectory to what we'd expect in neurotypical kids, but that the rates of these additional co-occurring conditions was much higher than we would expect in population-based samples. So it might be that having autism heightens the probability of having other conditions. I also wanted to briefly and quickly flag that there's also an increased risk of suicidal ideation. This is particularly in autistic girls. And again, I'm flagging this partly because it's something that's been under-recognised and under-looked at in general. And for anyone interested, the work by Sarah Cassidy's group is really important and leading the way in this field. And the other key thing is that if you ask people in the autism community, people taking care of autistic people, or autistic adults themselves who are able to advocate on their own behalf, supporting their mental health is one of their key priority areas for research. It's what they really want to see us doing more of. And a lot of the energy that they'd like us to invest in is particularly in sort of tackling things around anxiety conditions.
So just, I think just before I talk about the paradox, I thought it would just be helpful for you to know a little bit about the background that I've come at this from. So as well as the kind introduction that was given at the beginning, I now work exclusively in the realms of intersectionality and understanding the impact of autism in ethnically diverse communities and how schools, workplaces, healthcare trusts and everyone else can be more culturally sensitive in order to meet the needs of this particular group. And all of this has been inspired by my own journey as a lived experience parent of 2 boys, the eldest of whom has been diagnosed as autistic since the age of 4. He's now 10, and my youngest is on the pathway but is presenting with pathological demand avoidance traits and quite enhanced anxiety. So if you're wondering, I suppose, why Jeanne and I have been paired in this way, it is because of the project which we'll be talking about, which looks at really effectively bringing together the parent voice and the professional voice too. So just talking about the paradox here, there's a study that was undertaken by Cambridge University's Autism Research Centre. It was published back in March 2001, which looked at the data of 7 million school children, of whom 120,000 were autistic. And it found that the highest prevalence of autism was in Black, Chinese, and Asian pupils. And it's really interesting because when you look at other research, there really isn't enough, but research undertaken by Dr. Prithvi Pareppa from the University of Birmingham, who, as part of his study of autism in ethnic minority communities and how this impacts them, would ask, as part of his research and interviews, for families to refer others in their community who had autistic children to take part. And the resounding answer from those parents was, we didn't know anyone. They didn't know anyone. There was no one in their community that they knew who also had an autistic child. And it just really kind of highlights the paradox really between the two, that there are those who are diagnosed and are in the highest prevalence group, and yet when you ask people, they genuinely do not know. And this certainly echoes the experience I have when I work with parent groups, where the overwhelming feedback I get, regardless of which communities I'm working with, is that parents feel isolated. They feel like they're the only ones in their community who have an autistic child, and they are struggling a lot, from a mental health perspective, but also from a services perspective about how best they can support their child, but also integrate their child into their community. So I'm going to talk a little bit about why, in particular, some of the factors make this more of a challenge for Black, Asian and minority ethnic communities. So we know that this is, from the National Autistic Society's data, that the prevalence of autism in these communities is not a new thing. So when they did their research back in 2008, their findings also echoed that people from these communities were less likely to get an autism diagnosis, apply for any benefits, or even seek appropriate support, that the health and social care services weren't culturally sensitive and able to meet the needs of people from these communities. And there was generally a lack of awareness of rights and services amongst many of the Black, Asian and minority ethnic community groups. We know that there are over 100,000 children as at March 2022 awaiting an autism assessment, with that being an increase of 39% since April 2001, and that's NHS data. And yet the likelihood of that being an accurate reflection of Black, Asian and minority ethnic community people is actually, it's unlikely to be representative for a multitude of reasons. And these include the fact that assessments are not culturally sensitive. They are created with white male boys in mind, and so they often don't acknowledge girls' presentation or those of other cultures whose presentation is different. In many communities, there are what we would say are red flags for autism that would not be seen as red flags in these communities. For example, in some African communities, if children are not particularly, not speaking a lot, that is in some communities considered a sign of higher intelligence. In other communities, there are, the lack of pointing is culturally interpreted as inappropriate and rude, whereas often we see that as a marker for, as an indication that a child might be autistic. And there are many, many examples cited in Dr. Parepa's research that echoes similar examples like that. Furthermore, with communities from ethnically diverse backgrounds, there are often collectivist cultures, and there is a perception that the structure and the richness of that community, it can feel challenged and threatened when a child is diagnosed as having a hidden disability. And there's accompanying shame, denial, fear, the possible, it's seen as a threat to the success of that child and their future prospects, not just for them, for their siblings and for their broader family too. And what I've also found through many of the families I've worked with are that where parents are more open to working alongside their child's needs and overcoming these challenges, where they're sometimes living in extended families who are often have, say, parents-in-law who have come from abroad, it can be very challenging in a world where there is no word for autism in those cultures to explain how it is that this child is different when there is no history of this condition back home, wherever that home may be. We know also that from a health disparities perspective, that if someone is from a Black, Asian and minority ethnic background and also has a learning disability, around 40% of autistic people do have a learning disability. We know that if they are from a Black, Asian, minority ethnic background, they're also 20% more likely to die sooner. And that is reported in the Learning Disabilities and Mortality Review by the NHS, which has looked at key episodes of health and social care that people have received that are relevant to their health outcomes, and has analysed so far nearly 10,000 deaths of people with learning disabilities. And their reports have highlighted evidence of structural racism and disableism, which has led to preventable deaths. Furthermore, we know that there is data that shows that if you're 4 times more likely to be detained under the Mental Health Act if you're Black or Black British, without consideration of an autism assessment first. And also with regards to over-medication, a systemic review by the Race Equality Foundation looked at people with learning disabilities from Black, Asian and minority ethnic groups, and found that they are more likely to face barriers in accessing services and less likely to receive specialist services, as well as more likely to have poorer knowledge about the services that are available to them. From an education point of view, children from Black, Asian and minority ethnic backgrounds are twice as likely to be unlawfully excluded from school than those who do not have a special educational need. And for each child, the drivers and the reasons for exclusions are likely to be multiple, interwoven and cumulative, but factors that have been associated with the heightened risk of a child being excluded include the fact that they've got a special educational need, poverty, unsafe family environments, poorer mental health, low attainment, being male, being in particular ethnic backgrounds, and that's research published by Graham and others in 2019. The Greater London Authority also published a report in 2001 around ethnic disproportionality and found that Black, Asian and minority ethnic children are overrepresented at every stage of the criminal justice service, from first contact with police via stop and search to detention in the secure estate. And even though the overall number of children offending and reoffending and being sent to custody has decreased over the past 10 years, the proportion of children from minority ethnic backgrounds has risen significantly in each of these areas. And this data is also backed up by the National Autistic Society's report around the experiences of young people in the criminal justice system, which talks about double discrimination. So the prejudice experienced both due to being from particular cultures, but also due to being autistic.
There's certainly an awful lot to consider. In some senses, there's evidence that Black, Asian and minority ethnic communities, there's higher prevalence rates of autism, but on the other hand, you've described a lot of factors which mean that maybe they aren't being seen by services because they're getting their diagnoses later. Do you think at the moment we are under-diagnosing or over-diagnosing? What's your sense of the picture?
So there's data from the Department of Education that was published last year, which showed that 2.2% of the school population is autistic. Mm-hmm. That has increased by 9.5% every year since 2015, 2016. But despite that, some ethnic groups, such as Pakistani groups, are showing a lower rate of autism diagnosis than what we would expect compared to, say, white British groups who have higher rates. And so, yes, I do think that there are whole groups of children from these communities who are being missed. We also know from data from the University of Birmingham that children with English as an additional language are less likely to have and go through that process of having an autism diagnosis. So certainly social and economic deprivation is again another factor, another barrier to preventing people from these communities accessing the assessments and diagnosis.
Yeah, absolutely. And I suppose if we also steer the conversation a bit towards thinking about mental health, what do you think the impact is of all these various different factors interacting on what's happening to the well-being of that family unit as they're having a child who is going through the autism assessment pathway.
Yeah. So I think, I mean, there's so much to say on that, but cultural and linguistic barriers make it harder to access support and services for parents from global majority backgrounds of autistic children. There's also stigma and a lack of understanding about autism within communities, which can just add to the stress and the isolation that families feel. And, you know, autistic children often do struggle with social interaction, with communication, sensory processing, and other mental health issues too, and difficulties with transition and various things. And all of these factors together can really increase stress levels for not just the child, but the family as well, particularly when, as I mentioned, like, this is not something that families and communities are openly talking about and sharing. There is a lot of judgment. Even yesterday I was running a group and parents were saying, I'm on board with all the empowerment stuff, but it's just when I walk anywhere with my child, people are staring at me from my community. People have stopped going to the mosque to pray because they feel that they're not welcome now that they've got a child who presents differently. And so all those usual sources of support that families have, if we think about the places that we seek solace whenever we're stressed, if one of those places is a place of worship, that is now, for some families, it feels inaccessible to them because there is a lack of understanding and acceptance in many communities, but also because that we're not I don't feel like there's enough that's being done to address that. It's not just about the communities, it's about the structures in society to help promote that dialogue within these communities too.
Yeah, it's tackling and thinking about it at different levels and how you affect change in different systems to kind of break down those barriers and the stigma so that people can get support from their community, but also society as a whole.
Yes, absolutely.
So with all of these things in mind, obviously a research project can't tackle all of these things, but the contribution that we thought that we could make and where we could start, and the project that Reena and I work on together, Reena is on the steering committee of the Chatter project, is kind of this first step. So trying to think about how we can actually make the autism diagnosis procedure more culturally appropriate and more timely for the global majority. And, this is highlighting kind of what Reena said earlier, because it's important to remember that most of the tools that we have for diagnosing autism were normed on North white American boys. And so really not appropriate when we think about autism more generally as something that is bound up in culture because it's about social communication. So our baby steps in this world are the Chatter project. Chatter stands for Children's Autism Technology Assessment, and it's a project funded by a private donor called Patrick Poole, and it's a collaboration between an autism diagnosis service in East London, in Newham, and the Institute of Child Health at UCL. The reason why there's an umbrella in our logo is because Chatter means umbrella in Bengali. And it's really important to understand the context within which the Chatter project is operating. I said it was in Newham, which means that 80% of the borough, and that's kind of the population attending services, is from an ethnic minority background. And this means that most of the families are having interpreters in their sessions with their paediatricians and clinicians. And there is an exceedingly large number of children on the waiting list, waiting to be seen for their autism assessment procedures. So they're waiting years before they're being seen, even if they've been identified early. But the service that we're working with, Chand, has not been unique in the effect that COVID's had on it, in that a lot of services have started to be delivered online. So we're also trying to harness these changes to be able to drive down the time that it takes to run the assessment procedure so that we can deliver part of it online. So broadly speaking, the aims of the Chat project are to develop online alternatives to the standard autism assessment in a way that can better serve the community of Newham, making sure in the process of doing this that this new procedure is both equitable and time efficient. We're focusing on the under fives population because ideally we want everyone to be seen and receive a diagnosis before the age of 5. And then we've kind of got quite a few guiding principles alongside this for the project. The first of which is that whatever procedure we manage to create, it will be made available to other NHS trusts. And the emphasis here is on it being freely available, because at the moment, what's recognised as the gold standard for an autism assessment, or part of an assessment procedure, is a tool called the ADOS, and you have to pay quite a lot of money to be trained to use the ADOS, but also to go on workshops where you make sure that the reliability of using the assessment hasn't drifted over time. So we need to have a procedure which is open and doesn't have a cost attached to it. And we need this procedure to be accessible to clients who don't have English as a first language, but also you have low levels of literacy in general. And this new procedure also needs to be more culturally sensitive than the current autism procedures are. I think there's been an assumption historically that autism presents the same across the world in different cultures, and actually there's lots of evidence to suggest that that's not the case. And crucially, if we're going to drive down this waiting list, we need to be able to be using as little clinician time as possible, with the caveat that obviously some cases are going to be more complex and will adjust accordingly. But those are the driving principles behind this project. So what do we see the solution to as being at the moment? Well, at the moment, what we're envisaging is a two-step procedure. One is having an online assessment which families can fill out either with assistance from someone over their phone, but we're trying to create it in a way where it's accessible to everyone online. And we're looking at lots of different ways of doing this. So in the first instance, this instrument is multilingual. And the languages that we're focusing on to start with are Bangla with the Sylheti and Dhaka dialects, and Urdu, because those are the ones spoken by the highest percentage of people attending the service, but we will look at expanding that in due course. And to try and make it accessible to different languages, but also different levels of literacy, we have had translations of all of our questions into these different languages, and those translations have also been recorded as audio files so that people can listen to the questions that we're asking them online. But we also have written translations and transliterations, because it's not a given that because you speak Urdu you can also write it or read the classical form of it. In the fullness of time, we're also working towards having pictures and potentially in the future also videos illustrating some of the behaviours that we're trying to ask people about, so that they can say whether those behaviours are happening at home or not. So that's the first step. And then the second step as part of the assessment is having a virtual call with a clinician, where there'll be a bit more of a behavioural assessment to check whether some of the behaviours are happening, or to gather more information if we think that there are other key pieces of information that are being missed. This sounds like two simple steps. It absolutely isn't. We're in the middle of a feasibility project which will lead on to a pilot, and every step of the way there's co-production involved, and we keep going back to our stakeholders, to focus groups run through the service in Newham, to Reena, to anyone who wants to feedback on the project and the procedures, and we keep tweaking it incrementally, because I think the key thing to remember here, in what Reena said earlier, is not all cultures or languages have a word for autism. So there's a lot to be done in kind of communicating what this assessment is about, not just what the assessment procedure itself entails. And we're trying to create a procedure that is going to be inclusive and meaningful to as many groups as possible, by making sure that co-production is embedded every step of the way.
About 3 minutes, Jeanne.
Thank you. So before we leave you, I wanted to hand back to Reena for kind of the key take-home messages that would be helpful for everyone to kind of take home, bearing in mind that we know that a lot of you in the audience are either researchers in mental health or neurodevelopment or clinicians yourselves.
Thanks. I think my key takeaways would be, think about how representative your data sets are. Use and collaborate with organizations that have access to the demographics that you're targeting. You don't have to start from scratch. There are lots of groups out there that you could just tap into and collaborate with to access the groups of people you want to serve based on the project you're doing. And also, I guess, even as from the voice of a parent, the parent is the expert in that child. If the richness of data is the amount of time kind of spent on any subject, then no one can trump the amount of time a parent spends with a child. And so often the parents don't see themselves as experts. So utilize and acknowledge that expertise when you're interacting with parents of autistic children, particularly from global majority backgrounds.
So those are our calls to action for you. And with that, I'd like to thank you for being here today. And this is a little snapshot of the rest of the chatter team. Thank you.
Jeanne and Reena, thank you so much for that, and absolutely fantastic. Such a huge range of issues there to touch on, and really impressive to see the feasibility study unfolding and all the co-production. I guess it really struck for me kind of these really key issues about lack of representation in many of the research studies that we've had. And I hope that finally this is something that kind of a lot of the research funders are also turning their eye on and making sure that people recognise the need for people who aren't represented to be included in studies, for their voice to be heard. Really struck by something that's so key about the views of people, both with lived experience, but also parents and carers who absolutely are the experts here. So fantastic range of important issues to touch on, and then something very pragmatic that you're doing to try and address this in Newham. So yes, many thanks. So once again, I will stop talking and open the meeting up for people's questions or comments, either to Jen, who talked to us about the increasing incidence of common mental disorders in cohorts, or indeed many of these issues that have been raised by Jeanne and Reena. Essie has got her hand up to save me.
Hi, I think there's probably something in the chat as well, but so I wanted to I had a question for both, so I'll start with the first talk. To what extent have you been able to look at whether the mental health increase patterns sort of sync with changes or slightly lag behind changes in government policy that has really impacted people's socioeconomic circumstances, for example?
That's a great question. Thank you so much. And that aligns very closely with my main research interests, is trying to understand how things like broad economic policies or broad structural changes actually do impact. That's something that we're still trying to grapple with. It's very tricky to do that in the data that we have available, because the precision of when certain policies are implemented and they have an impact can be really challenging. So that's absolutely something that we're exploring. In the analysis that I presented today, we weren't able to look at that level of detail, but I think it's really fascinating, and I would be really interested in having further conversations about that.
And I have a quick question to Reena and Jen, and then I'm going to shut up. So I think this cross-cultural research is so important for a number of reasons. And one of the things that I've sometimes thought about, and not just in relation to neurodiversity, but also in relation to other conditions, is what role the culture plays in terms of whether these sorts of features actually are not only whether they're recognized or not, but also whether they, to what extent they impact the person socially or impact their mental health. So I'm also wondering whether there are also things that can be possibly learned or from other cultures, which means that perhaps people with particular kind of neurodiversity fare better in certain cultures than others with lesser consequences. And I'm not saying that's the case for what you are looking at, but I'm just wondering whether, given your experience, what your view would be. So my sort of take is that our Western white society is incredibly sort of education professional focused, and certain, you know, something like ADHD might be more harmful than is in a community where that isn't so much emphasized as the be-all, end-all, holy grail of a career pathway. So I'm just wondering what your thoughts are there.
Essie, I think we could do a whole webinar on that one question. I think there's a couple of things that come to mind, though there'll probably be much more. Firstly, representation. The power of representation cannot be overstated. When families see other people with children who look like them, who are going through a similar experience, it is extremely powerful because it normalizes, you know, what they're dealing with. You know, it is, as I said earlier, it's the most common thing I hear. People do not think that there are more people in their community. So when you tell them that their community has one of the highest prevalence of autism, you just wonder, where is everyone? And often, you know, sadly, there are a lot of families who are afraid to take their children out into the community because of the fear of judgment. There is some amazing work going on through particular organizations, but it's very patchwork. There are, you know, some fantastic organizations specializing in ADHD and Islam who are doing lots of advocacy, and then lots of groups like that. But it's, you know, if you don't know about them, you wouldn't, you know, kind of people wouldn't know to access them because they are really small. So there is, I mean, the representation, so even from not just, and I don't mean performative representation in literature, I mean, actually, you know, really engaging with what's important to people from particular cultures. Something that Dr. Parepa talks about in his book is the attitude that people have towards disability is so intertwined with people's faith. So where in some cultures people feel that the child's disability is like a cross that they have to bear, that is something they have to endure, they're less likely to ask for support, to seek advice and things like that. Whereas those who see it as a God-given challenge to raise this child are the ones who are going out there, kind of, you know, asking and knocking on all the doors possible, even if English is difficult. So, you know, you can't separate a person from their culture. So it's really important that the services have as broad an understanding as possible of how different cultures show up, because just, you know, if you meet one Pakistani Muslim family, that is not representative of all Pakistani Muslim families. You know, there'll be so many factors as to how people's attitudes towards their child's autism or other neurodiversities are shaped. And that, you know, includes socioeconomic disadvantage, the level of education, the acculturation in this country, you know, so many factors. So the broader you can expand your net of understanding, the more likely you are to reach the people that you want to reach. And I hope that answers.
That's really helpful. Thank you. Really helpful.
And I think the brilliant thing about all of those things that you've just highlighted, Reena, is that they're also applicable to how we think about mental health and how that sits within people from different cultures and different contexts. They're all themes that work on different levels if we are mindful of them and able to put some actions in place.
Great. Thanks for your questions, Essie, and the responses there. I can't see any hands up, but there's a couple of questions in the chat. One from Fiona John. I don't know whether you want to speak to Fiona or if you'd like me to read it out for you. Can't hear anything. So it says, particularly we're interested in chatter and thinking about the assessment. We can see how the pre-assessment online questionnaire could replace the ADIR, but unclear whether the child would be seen directly as part of the assessments, and also a nursery is included in the assessment process.
Very good question, and I wasn't very clear about this because I went through the project quite quickly. But we would see the child as part of the clinician online assessment. The child has to be there, and there'll be tasks for the child to perform as part of that assessment. We are following a protocol from something that already has some evidence to it called the tele-ASD PEDS, but we're going to be amending it substantially so that it's more culturally appropriate. But great question, thank you.
And in regards to sort of other professionals' involvement and things like that, so SLT, OT, would they be able to complete the pre-assessment questionnaire, or would certain parts be sent out to them?
Excellent question. Once we've kind of got the pipeline together, the ambition is that it would be able to be delivered by other specialists within the MDT providing the autism assessment, but we'll need to test it and see whether we get reliable enough ratings from it. And the other thing I haven't mentioned is within the context in Newham, typically families are seen for kind of like a medical physical examination before this process happens. But that again may be something that we're able to revise as part of the pilot.
Great, thank you. And then another question in the chat from Sue, which says, what can schools do to support whilst the waiting lists for support grow? I'm not sure which talk that's aimed at, but probably relevant for both. So I don't know, Jen, if you want to say anything about what schools might be able to do, or if Jeanne and Reena want to jump in on that.
I'm looking forward to hearing Jeanne and Reena's answer to this. I do think that there is some really interesting work that's happening in schools. My research, I have not focused on the school environment in my research, but I'm aware of some other researchers within the public mental health program specifically that are looking at how school environments can impact on the mental health of children and adolescents. And so I would say that that research would be potentially a starting point to look at the ways that school environment can be shaped and changed in order to better support the mental health of children and young people.
In
Yeah.
terms of,
Oh,
yeah, no, we're both going to talk. In terms of kind of support for kids on the waiting list for autism assessment, there are other projects kind of looking into doing that specifically, which is fantastic. But I'm going to hand you over to Reena, who's probably going to have more practical insights.
Well, all I was going to say is this is something that I do. So I go into schools. I'm commissioned by schools to come in and run sessions for parents for children who are awaiting assessment, or where there are autism presentation. There's autism presentation, and so the sorts of things I do are talk about what it is, talk about share parenting strategies, literal models that are evidence backed around that can help promote emotional intelligence and understanding that children, and creating a home environment from a needs-based perspective, rather than often what can be done is an inherited traditional cultural perspective of obedience-led parenting, which can clash when you have a child who is demand avoidant. So really helping parents on that journey to, because this isn't something that often comes naturally to parents from global majority backgrounds, and certainly I was not parented in that way either. So I can empathize and I share my own lived experience and then share the strategies that's data backed, but also with schools. I work, I'm also the chair of governors of our school, as well as the inclusion governor, and I work with schools to talk about inclusive governance and to talk about how to make staff and also curriculums more inclusive from a global majority perspective. So it is possible. Anything's possible. You just have to want to do it.
What a fantastic way to end, actually, Reena. Anything's possible. I would like to, I can't see any more questions in the chat, and I've seen a few people expressing their gratitude for really excellent and thought-provoking talks today. So I think perhaps that's time to wind up the seminar, and just to say a huge thanks to Reena and Jeanne, and to Jen, who's in a different time zone from us as well at the moment. So really thought-provoking, really emphasising this fact that whilst with best intentions, a lot of research has been highly underrepresentative of many different groups, and it's so important that we try and address that going forward. So thanks again to all of the speakers and to the people who've attended, and of course the recording will be available. So thank you very much. Bye now.
Thank you.